Good morning, everyone. Over the next 20 minutes, I'll take you through the topic of right heart failure. And the objective of my talk is basically to achieve clarity on a very nebulous topic. So I would like all of you to forget what you know about the right heart for the next 20 minutes, and then let's build up everything from scratch. Now, I'm sure during your school and college days, or even your professional lives, you would have read this comic on Asterix. It's quite a famous comic, and now you can basically draw a correlation between this comic and the heart. So basically, the rest of the Roman Empire is a baggy right ventricle, and what drives the entire story is the powerhouse, which is the left ventricle. And you will see a lot of anecdotal evidence towards this. Right, so the commonly asked questions in everybody's minds with regards to the heart is, why is the right heart not very different? The second question is, why is it actually different? Why is it such a pain to treat it? Why do we not care sometimes, but sometimes why do we need to care? What should we do if we have to treat it? So these are the primary questions in every clinician's mind when you're dealing with the right heart. So the first question, why is the right heart not that different? Because it basically depends on the three factors which even the left heart depends. That is your preload, your contractility, and your afterload. Inflammation and sepsis causes RV dysfunction, less like it causes LV dysfunction. Hypertension is something both the ventricles don't like. The RCA is prone to coronary disease, just like the LCA, but probably there's a more preponderance to the RCA because anatomy-wise, there is a preponderance to have a right dominant circulation in the coronaries in most people. And it has an arrhythmogenic potential, although slightly higher than the left side. So these are the reasons why the right heart is not that different. However, the next question, why is it actually different? Because it's highly compliant. It's a very baggy chamber. Less muscular, it likes a faster heart rate. It has a complex anatomy as opposed to the left heart. Like for example, I'm sure all of you would have seen a Pringle chip. The right heart is something like that. It's got a lot of sadly wavy patterns to it, which makes it slightly different from the left side. Now, coming to the anatomy, its volume is greater than the left-sided volume. It has a higher end diastolic volume as a result of that. And its muscle mass is only 1/6 of that of the left ventricle. So these are the reasons why it's different from the left side. Remember, the RCA perfusion occurs in systole as well. The left side heart, the perfusion of the coronary occurs purely in diastole. That is, the right heart, the right coronary artery gets its blood supply in systole as well. It's sensitive to pulmonary vascular resistance. And any factor which affects the PVR, like hypoxia, hypercarbia, acidosis, or increased airway pressure, is detrimental to its functionality. So that's a schematic showing your right heart and the left heart. The right heart, the pressure is about 20. The left heart, the pressure is about 120. So that's a difference of heaven and earth between the two chambers. Now, this particular chart, it basically tells you what an afterload does to a ventricle. So, right. So this on the vertical axis is your stroke volume, and that's your left ventricle and your right ventricle. However, due to whatever reason, if the PVR goes up, it could be secondary to hypoxia, hypercarbia, patient is aspirated, ARDS, anything which increases the PVR, you will see that the right ventricular stroke volume starts going down. That's secondary to the fact that it's quite a baggy chamber and it's not as muscular as the left heart. So it tends to struggle. So PVR is usually a make or break in the functionality of your right ventricle. Coming to the left ventricle, it tends to cope a little better. And this is the reason why when you have a high SVR with regards to your left ventricle, that ventricle tends to maintain your pressure better than the right ventricle. And this is the primary reason why people with long-term heart failure survive for their course of life, because they survive on a high SVR. And that is what transfers the blood to the vital organs for their perfusion. So this is probably the biggest difference between the two, and the reason why the right ventricle is such a fragile thing. Now, points to remember up to so far. a chronically hypertrophied right ventricle usually tolerates a high pulmonary artery pressure because it has had physiological time to cope and get hypertrophied. However, in an acute situation, it will unable to deliver a PAP of greater than 50 because it starts to fail, and that's what happens in acute right heart failure. It cannot tolerate a PVR which is high. So the next question, why is right heart failure such a pain to look after? It's because it's harder to diagnose and monitor, because most of the time people have a central venous line, which is not a great way to monitor right heart pressures. Secondly, it has a complex geometry, like I mentioned earlier, and it has complex ventricular, that is your left ventricular and intraventricular septum interactions. So this is something, it's always nice not to buy an apartment which has got common walls. That's basically because of this. The right ventricle and left ventricle, although they are individual chambers, they have an intraventricular dependency, which I will touch on shortly. Now, this is just a table to show you all the causes of acute right heart failure. So it's all there on the slide. But what I want to draw your attention to is this particular LVAD support thing. So that is a bit of a red herring. Now, it's quite imperative that when you plumb in an LVAD into a patient, you have to make sure that your right ventricle has been optimized. If you do not optimize your right ventricle, the LVAD is a machine. It will do exactly what it says on the box. It will deliver a cardiac output dependent on the flow you have dialed. So if you set up a flow of, say, arguably 3 liter, 3.5 liter, that much of blood is going to come back full circle into the right side. And if you haven't optimized your intravascular volume and you haven't optimized your right ventricular functionality, your right ventricle will fail. So an LVAD therapy is something you need to take with a pinch of salt. It only supports the left ventricle and not the right. And this is a mistake which happens many a time, because if you haven't actually taken care of your right ventricle and you're plumbed in an LVAD, it's probably going to fail. For the sake of completion, I've just touched on chronic heart failure. Same 3 things: contractility, overload and pressure overload, volume and pressure overload. A lot of congenital deformities which are there on this particular chart: cardiomyopathy and your acute cardiomyopathic arrhythmia, arrhythmogenic right ventricle cardiomyopathy. That's what ARVC stands for. What are the manifestations of right heart failure? There's a whole list of it. Now, basically, it causes venous congestion. So there's a back pressure in your IVC, and that causes a lot of problems into your abdominal organs, and you develop something called a cardiohepatic syndrome, which basically develops secondary to venous congestion as the liver gets its majority of its blood supply from the portal vein and not the hepatic artery. And as a result of this, you have hepatic congestion, which throws your clotting out of the equation. The other problem is your cardiorenal syndrome, which again happens secondary to the activation of your ARAS, and that basically causes your kidneys to malfunction over a period of time. So it has got fallouts with regards to the liver and kidney, especially when you're looking at right heart failure. Now, when it comes to signs and symptoms, clinically, these are all the signs and symptoms which you look for. You have small little things which start developing early, like your parasternal heave, you develop a gallop, and eventually your patient becomes like a Michelin man. He gets puffy, he gets popped up, he develops ascites, he's not looking good. Now, the diagnostic tools, there are several. However, echocardiography and a PA catheter take the middle stage because it's got features which can look at all the 3 aspects of your heart: your preload, your contractility, as well as your afterload. Lots of other parameters are there, but they don't actually provide that much of evidence as the other 2. So these 2 take center stage with regards to monitoring or clinically diagnosing right heart failure. Now, echocardiography, there are scores of indices, there are scores of tests which you look at with regards to right heart failure. However, echocardiography, when it's used as a tool, remember, it's a dynamic process, and it totally depends on the skill of the echocardiographer to be able to give you a diagnosis of right heart failure. So that's not something which is easily done. It takes a little bit of experience for them to nail the diagnosis early, because that's what is important. You don't want the horse to bolt before you actually close the door. You need to treat it in time, and you need to treat it adequately. Now, why do we normally not have to care? Because the position of the intraventricular septum is obviously determined by the chamber pressure differences on both sides. So if your LV is high pressure, the septum bows to the right. and contralaterally when your RV is a problem. Normally, your left ventricular end diastolic pressure is always higher than your right ventricular end diastolic pressure, and usually your septum will bow towards the right ventricle during diastole. So this is what normally happens. But then when you have a pressure buildup on the right side, the septum will bow to the left, and when that happens, automatically your cardiac output will fall, your coronary perfusion will fall, because your left ventricular end diastolic volume has fallen, and that is what supplies oxygenated blood into the coronary, and automatically your vicious cycle is in place, because your RCA starts getting less oxygenated blood, and it goes downhill. Now, when we look at your pulmonary dysfunction, why does PVR or a failing left ventricle induce right ventricular dysfunction? Obviously, there is a back pressure effect which you see. So firstly, we talked about this earlier, there is an increase in your afterload to your right ventricle. And that causes the displacement of your intraventricular septum towards the left ventricle because the pressure has built up. Then there is impaired right ventricular filling because it's a bag. It's basically a or a poor muscle bag where it doesn't have the capacity to contract that much. So it starts filling and filling and filling, and it gets blown up. And as a result of that, your intraventricular septum will start bowing towards the left. Then you have pulmonary disease, again, back pressure secondary to the PVR. So these are all the states wherein your right heart will start acutely failing. So it's quite important to keep this in mind when you're looking at patients from a holistic view. I do agree, ventricular failure doesn't occur in isolation. You'll never have isolated RV failure. You'll never have isolated LV failure. It's always a conjunction between the two. But what takes the cherry on the cake is which one is clinically more significant as opposed to the other. So why do we actually have to care? I've told you all the reasons why we don't actually have to care, but now sometimes why do we have to care? So when you have RV dysfunction, obviously we talked about ventricular interdependence. We have systolic and diastolic dysfunction, automatically causing a low cardiac output state. Secondary, when you have purely systolic RV dysfunction, it again leads to a low cardiac output state. Any arrhythmias which come along the way again cause a low cardiac output state. If you have tricuspid regurgitation, it again causes a low cardiac output state because the blood is going backwards instead of forwards. Then you have circulatory failure as a result of your low cardiac output state. Now, when you have pure diastolic dysfunction, what is diastolic dysfunction? It's basically non-compliance of your ventricular cavity. So it starts getting more and more stiff. The reason why it gets more stiff is because it's non-muscular, like the left ventricle. And because it's non-muscular, even though there is an entity called a Frank-Starling's law, which says that your force of contraction is directly proportional to the initial length of your muscle fiber, that particular ventricle is not capable of contracting because it doesn't have the oomph to do it. And that's why it fails. So you cause increased shunting if you have an intracardiac defect. You develop hypoxemia as a result of that. You have a congestive component due to the back pressure into your IVC, your liver, the kidneys start getting hit. And then automatically you develop fluid retention, and you develop a congestive liver, and you develop a coagulopathy. So all these things are the pathophysiology of what happens during right ventricular dysfunction. Now, we'll again touch briefly upon the right ventricle to left ventricle interdependence because they share the pericardium, they share the septum, and the myocardial fibers don't actually know which side they're going. So that's why there is an intraventricular dependence when we talk about the heart. Each ventricle affects the other with regards to its size, shape, and your pressure-volume relationship of each ventricle in isolation. Now, just a quick schematic on what happens when you have a pressure overload buildup in the right ventricle, like in an acute heart phase. So when you have a pressure overload, obviously there's a stress which goes up on your myocardium. So when there is increased stress, over a period of time, given time, it kind of adapts to it and it develops thickening. So that is like what you see in your CTEPH patients or your PTE patients, where they have a hypertrophic right ventricle. But in an acute phase, the heart has not had the chance to compensate by increasing its muscle mass. So as a result of that, you develop a decreased coronary perfusion pressure and a higher demand for oxygen, which causes ischemia. Secondly, when there is RV distension, there is obviously left ventricular filling which gets affected because the septum is starting to bow towards the left side, which automatically means your left ventricular and diastolic volume has gone down. As a result of that, your cardiac output will fall. So the vicious cycle is well and truly in place. Now, what are the ICU-relevant conditions that can worsen right heart failure? Now, hypoxia, we touched on it, hypercapnia, any kind of metabolic acidosis, or mechanical ventilation. So why mechanical ventilation? Basically because your intrathoracic pressure goes up, the preload to the RV comes down. If the preload comes down, automatically the volume comes down. When the volume comes down, it can't pump. And then if there is an increase in PVR, your afterload to your right ventricle goes up, and as a result of that, you have a fall in cardiac output. So the dictum is, the take-home message in this slide is, when you have a patient in RV failure, whenever feasible, try to get them off any form of IPPV. An IV, intubated, tracheostomized patient, try to get them off a ventilator. Your right ventricle will thank you for it. However, in the left side, the story is different. The left ventricle likes IPPV. The right ventricle does not like it. So you need to draw a line because of the intraventricular dependence, which is the heart failure which is worrying you most. And if your right ventricle is the one which is worrying you, try to get them off the ventilator quickly, and that will hold you in good stead. Now, this particular slide is a quick representation of this PVR. This PVR is a big spanner in the works. And unfortunately, unless you have a PA catheter in place, you're not going to be able to diagnose a rise in PVR. So if you do have a chance to put in a PA catheter, it will throw complete light on the picture and everything becomes black and white. So the dotted line is the PA catheter. As you can see, your PVR is going up over a period of time. And this is the reason why your CVP becomes a poor marker, because the CVP is not changing when your PVR is actually going up. By the time it changes, it's too late. Then you look at your PA pressure. Your PA pressure starts going up initially till a particular point. Now, when the PA pressure goes up, it's quite important to remember that a rise in PA pressure is secondary to a physiological adaptation of your ventricle to contract. So it is getting the PA pressure up. But then, after a particular period of time, your right ventricle will fail, and your PA pressure starts going downhill. And as a result, your cardiac output goes down. So a rise in PA pressure is not always a good sign. A fall in PA pressure is not always a good sign. That's the take-home message from this slide. Now, specific considerations, we have touched on most of it. Post-cardiac transplant is probably the most important thing because your right ventricle is something you look after like a baby after a heart transplant. If your right ventricle fails, everything you have done is going to be in trouble. We have done this. So how should we treat it? You treat the underlying cause, whatever LV failure, back pressure effects, PVR, infarction, endocarditis, ARDS. You treat it. You treat the confounding factors which we have touched on. Avoid high ventilatory pressures because it doesn't like it. Now, optimization pathways, obviously preload. We touched on CVP. Keep them dry. Try to not give too much of volume. It's not a good thing. Role of bedside ultrasound. Yes, nowadays a lot of clinicians are developing that skill. So yes, you can look at your IVC sizes and then decide on your fluid. PA catheter, by far, gold standard. You increase contractility, you choose dobutamine, you choose milrinone, you choose levosimendan. You choose any of these things which will work as an inodilator. However, bear in mind, when you have AKI, which happens secondary to your cardiorenal syndrome, milrinone and levosimendan not a great drug to use because it will start slowly poisoning your kidneys, and something like levosimendan, once you set it in, it's in your system for about 5 days. So it becomes difficult to get rid of it. What happens in liver insufficiency? Again, your active metabolite remains in circulation, so you will have a fallout of a reduced SVR over a period of time. So what do you do for treating your fallen SVR? You will end up using a vasoconstrictor. NORAD, not a good choice because it increases your PVR. Vasopressin, better choice because it's benign to PVR. So if you end up in a situation where you use an inodilator, you want to get the BP up secondary to falling in SVR, you start using vasopressin. It's a better choice. How do you reduce the afterload? You can use nitric oxide. However, remember, you have responders and non-responders. Only if you're able to activate your guanylate cyclase, your patient is deemed a responder. So that is something only time will tell. You introduce nitric, wait for 30 minutes. If your PVR is not coming down, it's a non-responder to nitric. No matter how much you give, it's not going to work. You can use GTN because it's a prodrug. You can use nebulized GTN, and that will do the job. Again, if you have an activated guanylate cyclase, because the pathway is common. Nebulized ileoprost, yes, you could use it. Expensive option, not easily available, but yes, you could use it. Sildenafil, easily available, but then again, it causes hypertension, so you need to be a little watchful. Bosentan is always going into the sunset now because of its hepatotoxic effects. A lot of people don't try to use it anymore. Abrupt discontinuation will cause a rebound PH, something to bear in mind. Mechanical support, percutaneous RVADs is something you can think of. The thing you see in the picture is called a Protect Duo, wherein you put it through the right IJV. It's done under fluoro. You put a PA catheter in, you guide wire your PA catheter, you remove your PA catheter, you put serial dilators, you introduce the Protect Duo. The tip of your Protect Duo should be about 1 inch from the bifurcation of your pulmonary artery. Because it has a tendency to flip into either side, it will cause unilateral pulmonary edema when you start giving 3 liters of flow down that catheter. Yes, it's available, it's doable. If you do it correctly, you will bail out your patient. You don't have to have a cardiac unit on standby to put an RVAD in. A BiVAD, yes, technically yes, because like I said earlier, no ventricle exists in failure in isolation. There's always a biventricular component to it. Artificial heart is an option, not yet come to India. ECMO, yes, it's a bailout option. You can put them on VA ECMO and then wait for things to resolve. Heart transplant is the final frontier. You could consider doing that, but then there's a lot of loopholes to go through before you actually deem a patient fit for a transplant. So at the end of the day, you look after your right ventricle like a baby, and when you look after it, your LV will thank you for it. Thank you so much for your time.